Welcome to the Deep Dive. Today we're plunging into the profound impact of some of the body's tiniest organs, the parathyroid glands. You might be surprised to learn how these small, often overlooked glands wield immense control over everything from your bones to your brain. Our mission today is to give you a master-level understanding of these vital glands, tracing their remarkable history, exploring their intricate functions, and unraveling the complex conditions that can affect them.
Absolutely. Our source for this deep dive is a crucial excerpt from SABISTON Textbook of Surgery, 21st edition, specifically the chapter on the parathyroid glands by Uliana Bobanga and Christopher R. McHenry. We'll be extracting every critical insight, connecting the dots to truly equip you with the knowledge that elite professionals in this field would master. And to really grasp their significance, we first need to understand their surprising journey into medical knowledge. It's quite a story.
It really is, because the path to understanding these glands is a medical detective story in itself. For something so critical, their discovery was incredibly late in the grand scheme of medicine. It's genuinely fascinating to think how recently we uncovered their importance. The earliest reference, believe it or not, comes from Sir Richard Owen back in 1862. He described a small, compact, yellow glandular body attached to the thyroid gland, not in a human, mind you, but in an Indian rhinoceros.
Right, in a rhino.
It wasn't until 1880 that a keen-eyed 25-year-old Swedish medical student named Ivar Victor Sandström first identified them in human cadavers. He was so meticulous he even named them glandulae parathyroidea and provided incredibly detailed descriptions. Imagine making such a foundational discovery as a student.
And this discovery immediately presented a puzzle for early surgeons. You see, just a year earlier, in 1879, Anton Wolfert described severe muscle spasms.
Tetany.
Postoperative tetany, right? Exactly. In Theodore Billroth's first patient to survive a total thyroidectomy. The connection wasn't immediately obvious, but this clinical observation was a critical piece. It wasn't until 1891 that Eugene Glay, a professor of physiology, recognized the direct association.
Ah, Glay.
Yes, he reported tetany and, death in rabbits and rats after their thyroids were removed, along with these newly described glands. That was a crucial experimental link.
Okay, so linking the glands to tetany. But how did this connect to the widespread bone disease seen at the time? That seems like another leap.
It was, and initially it led to a misunderstanding. In 1891, Friedrich von Recklinghausen reported on a patient with, multiple fractures, bending bones, cystic changes. He termed it osteitis fibrosis cystica.
OFC, yeah.
Then in 1904, Max Askenazy identified an association between the severe bone condition and parathyroid disease, finding a parathyroid tumor in 2 patients. But here's the kicker, as you said. At that time, they actually hypothesized that the parathyroid changes were the result of the bone disease, not the cause.
Wow. So they thought the bones went bad first.
Precisely. They even treated patients with parathyroid extract, thinking they had a deficiency causing the bone problems.
Incredible how understanding can be completely inverted.
It is. The real turning point, the major paradigm shift, didn't come until 1915. That's when the severe bone disease was finally considered to be the result of changes in the parathyroid glands. Dr. Friedrich Schlagenhofer, a pathology professor in Vienna, reported autopsy results in 2 osteomalacia patients who had solitary parathyroid tumors. He boldly suggested that gland enlargement was the primary event and, remarkably, hypothesized that tumor excision might actually benefit patients.
That was revolutionary, shifting from deficiency to excess.
Exactly.
So building on that, the first steps in actually treating these conditions began to emerge, even if the full picture was still a bit fuzzy. In 1905, William McCallum showed that giving calcium or parathyroid extract could reverse or prevent that postoperative tetany.
Right, building on the earlier observation.
And William Halsted further reinforced this, using intravenous calcium gluconate for tetany and strongly emphasizing preventing parathyroid injury during thyroid surgery. He saw the practical side.
He understood the surgical importance, yes.
But even with these observations, the prevailing view was still, wrong. They thought the parathyroids detoxified blood, like the liver.
That was the common belief then, yes. It just shows how science pieces things together, often getting parts wrong before the definitive breakthrough.
Which leads us to that breakthrough moment.
The definitive moment, the true understanding of the core function, came in 1925. James B. Collip, a Canadian biochemist, made a monumental stride. He used hot acid extraction to produce parathyroid hormone, or PTH, extracts. These extracts successfully reversed tetany in animals that had their parathyroids removed.
Okay, proving the hormone's role in tetany.
But even more profoundly, Collip and his colleagues then reported that repeated PTH injections in dogs produced hypercalcemia, high calcium vomiting, dehydration, even death.
Ah, so too much hormone caused the opposite problem.
Exactly. This was the definitive evidence. Collip proposed that the function of the parathyroid glands was, in fact, to regulate calcium metabolism. The true purpose was finally starting to crystallize.
And this new understanding immediately paved the way for the first truly effective surgical treatment. This story in Vienna, 1925, it sounds incredible.
It really was. Felix Mandel, influenced by Schlagenhofer's ideas, performed what you rightly called an epic surgery. His patient, Albert John, a 38-year-old tramcar conductor, suffered terribly from severe bone disease, what we now know as primary hyperparathyroidism, or HPT.
And Mandel operated.
Yes, on July 30th, 1925. He explored John's neck and excised a 2.5-centimeter parathyroid gland. The result was a dramatic improvement in his bone disease. This established the definitive link between osteitis fibrosis cystica and parathyroid enlargement, helping finally dispel that old belief about parathyroid deficiency.
A literal life-changing discovery. Removing the excess was the key.
Absolutely. And this groundbreaking work spread quickly. It led to the first recognized cases and formal definitions elsewhere, including the U.S. Captain Charles Martel became the first well-recognized case of primary HPT in the U.S. in 1932. He had severe bone disease, kidney stones, fatigue, classic symptoms.
And surgery wasn't straightforward for him either.
Not at all. It took 6 unsuccessful neck explorations before Edward Churchill and Oliver Cope finally located and removed a 3-centimeter parathyroid tumor from his mediastinum.
In the chest.
Yeah.
That highlights how elusive these glands could be.
Precisely. And just before that, in 1929, Barr, Bolger, and Dixon from Barnes Hospital in St. Louis formally introduced the term hyperparathyroidism. This was after their experience with Elva Dawkins, who had the first successful parathyroidectomy in the U.S. in 1928 by Isaac Olch.
So the terminology and understanding were solidifying.
Yes, rapidly.
With this new framework, the next logical step was categorizing and defining the condition comprehensively. And this is where Fuller Albright comes in.
Exactly. The brilliant Harvard physician Fuller Albright made immense contributions in the 1930s. He noticed that 80% of patients with OFC also had kidney calcification and stones, nephrocalcinosis, and nephrolithiasis.
Identifying key hallmarks.
Yes. He defined primary HPT perfectly as a condition in which PTH is higher than needed, and he categorized its causes: single adenoma, multiple adenomas, diffuse hyperplasia, and even cancer. Crucially, he also described secondary and tertiary HPT, distinguishing them from primary HPT. This provided a clear framework that's still foundational today.
It's amazing how we went from those late diagnoses of severe disease to the common incidental findings today.
It really is. And the answer, as you hinted, lies in technology. The modern era truly began with Leonard Skegg's autoanalyzer in 1951, and then the multi-channel autoanalyzers in the 70s. These allowed for rapid, widespread blood tests, meaning hypercalcemia was often detected incidentally before severe complications developed.
So routine blood work changed everything.
It really did. And parallel to this, PTH measurement improved dramatically. After successful purification, Burson used an immunoassay in 1963. Potts sequenced PTH in the early 70s. Rosalind Yalow won the Nobel Prize in 1977 for this kind of work. And by 1987, Nussbaum developed the 2-site assay for active intact PTH, highly specific and sensitive.
And these lab breakthroughs directly transformed surgery, didn't they? Leading to less invasive approaches.
Absolutely. While early PTH assays took hours, understanding PTH's incredibly short half-life, just 3 to 5 minutes, was key. This led to the development of a quick intraoperative PTH, or IOPTH assay, results in just 10 minutes.
A game changer in the OR.
Totally. Championed by Irvin and colleagues in the early 90s, IOPTH monitoring, combined with better localization techniques, enabled minimally invasive or focused parathyroidectomy. Imagine shifting from extensive exploration to targeted intervention, all thanks to a 10-minute test giving real-time feedback. Truly transformative.
Okay, let's shift gears and unpack the very beginnings of these glands, their embryological journey. This explains so much about where they can end up.
It really does. The 2 pairs of parathyroids develop from the endoderm of the 3rd and 4th branchial or pharyngeal pouches. These pouches form many face and neck structures.
Right.
The 2 inferior parathyroids differentiate from the 3rd pouch, along with the thymus gland, around the 5th week of gestation.
All right.
By the 6th week, they both detach and migrate downwards caudally. The inferior parathyroids eventually land on the back surface of the lower poles of the thyroid.
And the superior ones.
They form from the fourth pouch, attaching to the thyroid as it also descends.
So their journey is shorter.
Exactly. And that has direct clinical significance. Understanding this journey is crucial because it dictates where surgeons might find them, especially if they're ectopic, in an abnormal location.
Because the inferior ones travel further.
Precisely. Their more extensive migration explains why they're much more frequently found in ectopic spots. They have more opportunity to get lost along the way. The superior glands have a more limited path, so their location is generally more predictable.
Makes sense.
And it's fascinating how genetics plays a role too. A gene called GCM2 is a key regulator in their development and hormone expression. Mutations in GCM2 are linked to familial HPT and even a higher risk of parathyroid cancer. It shows how fundamental the genetic blueprint is.
So bringing this back to the practicalities of surgery, what's their typical appearance and location?
Right. Most people, about 84%, have 4 glands, 2 pairs. Around 13% have more supernumerary glands, and 3% have only 3. Normally, they're tiny, oval or bean-shaped, maybe 5 by 3 by 2 millimeters, weighing just 35-40 milligrams.
Really small.
Very small. Color varies from yellow-tan to reddish-brown, often surrounded by fat. Their main blood supply is usually the inferior thyroid artery. And importantly, each gland has very fine end-arterial branches that are easily damaged, easily devascularized during surgery.
Delicate work, then.
Extremely. While they're often symmetrical, about 16% of patients with primary HPT will have at least one gland in an ectopic location.
Which brings us back to that migration path.
Exactly. Knowing the typical spots and the common hiding places is paramount. They're usually found very close to the thyroid gland itself. Let's break it down. The superior glands are usually on the posterior surface of the upper thyroid pole, behind and above the recurrent laryngeal nerve. Their shorter migration means about 80% are found where expected, near the junction of the inferior thyroid artery and the nerve, often within the thyroid capsule.
So finding them can still be tricky.
Yes, usually because the surgeon needs to fully mobilize the thyroid lobe to see that posterior location. Ectopic spots for superiors include the tracheoesophageal groove, behind the esophagus, mediastinum, or even intrathyroidal.
And the inferior glands, the ones that travel more.
Right. They're typically found a bit lower below that artery-nerve junction, anterior and medial to the nerve. But they are much more commonly ectopic. They can literally be anywhere from the angle of the jaw down to the pericardium near the heart.
Jaw to heart. That's a huge range.
It is. The most common ectopic location for an inferior gland is actually within the thymus gland.
Inside the thymus. Wow.
Yes. Other spots include the anterior mediastinum, aortopulmonary window, carotid sheath, or even undescended near the jaw. This huge variability really underscores the need for thorough knowledge and meticulous surgery.
Let's zoom in even further to the microscopic level. What do they look like inside? How does structure relate to function?
Good question. Each gland has a capsule with fibrous septa dividing clusters of specialized cells, the parenchyma. Interspersed are fat cells, adipose cells, maybe 25-40% normally, increasing with age. This fat affects the color. Older glands look yellower.
And the key cells.
2 main types. Chief cells are the most numerous. They are the workhorses, synthesizing and secreting PTH. You can see the hormone granules inside them. Then there are oxyphil cells, larger, packed with mitochondria. They increase with age. Their function? Still a bit of a mystery, honestly, though they might affect how some scans work.
Okay, chief cells make PTH, but you mentioned something important about diagnosis.
Right. Crucially, just looking at the cells under a microscope cannot definitively tell you if it's an adenoma versus hyperplasia, or even normal versus abnormal.
So histology alone isn't enough.
Not definitively for function. Think of it like looking at a leaf. You know it's a leaf, but not if the tree is overproducing fruit. That's why intraoperative PTH monitoring is often more definitive for the surgeon during the operation.
Got it. Now let's dive into that core function, PTH, and the incredibly tight regulation of calcium.
It's a beautiful system, really. Extracellular calcium concentration is the main driver. It's a precise feedback loop. Calcium binds to specific calcium sensing receptors, KSRs, on the chief cells. High calcium hits the brakes, inhibiting PTH secretion and gene expression.
And low calcium.
Low calcium takes the brakes off, ramping up PTH production and release. Vitamin D, the active form, also plays a role, binding to receptors on chief cells and inhibiting PTH. PTH starts as a larger molecule, then gets cleaved to the active 84 amino acid peptide. The front end, the NH2 terminus, is the active part, binding to PTH receptors, PTHR1, mainly in bone and kidney.
Its primary targets.
Exactly, and the relationship between calcium and PTH is exquisitely tuned. Max secretion at low calcium, max suppression at high calcium. The body maintains calcium at a set point. This set point is sensitive. Small drops in calcium cause big PTH increases and vice versa. The CalSARs detect these tiny changes.
So what are PTH's effects? Where does it act?
Okay, three main areas. In the kidneys, PTH acts quickly. It boosts calcium reabsorption, less lost in urine. At the same time, it increases phosphate excretion. It also crucially stimulates the kidney to activate vitamin D.
Ah, linking to the gut.
Precisely. That active vitamin D then goes to the small intestine and increases absorption of dietary calcium. And then there's bone. PTH's effect here is complex, nuanced. It has both bone-building, anabolic, and bone-resorbing, catabolic effects.
How can it do both?
It's about context and pattern. PTH stimulates cells that form new bone, but it also indirectly ramps up cells that break down bone, releasing calcium and phosphate. In chronic high PTH states, like primary or secondary HPT, the net effect is bone loss osteoporosis. That's the catabolic effect. But interestingly, if you give recombinant PTH intermittently as a treatment for osteoporosis, it actually stimulates bone formation more than resorption, an anabolic effect.
Fascinating. Same hormone, different outcomes based on exposure.
Exactly. Finally, PTH has a very short half-life, just 3 to 5 minutes. And most circulating PTH, maybe 80%, is actually inactive fragments. Only about 20% is the active intact peptide.
Which is why measuring intact PTH is so important for diagnosis.
Absolutely. You need to measure the active hormone.
Okay, let's turn our focus now to the most common problem. Primary hyperparathyroidism, or HPT. This is where the glands themselves go rogue.
That's right. Primary HPT means excess PTH synthesis and secretion by abnormal parathyroid glands acting autonomously. Most patients present with hypercalcemia, high blood calcium, and an elevated or sometimes inappropriately high normal PTH level.
That inappropriately high normal is key, right? Because high calcium should suppress PTH.
Exactly. If the system was working, PTH should be low.
And how common is this?
More common than you might think. Affects about 1 in 500 women, 1 in 2,000 men, most often postmenopausal women, 50s, 60s. Incidence increases with age. Primary HPT and malignancy are the top 2 causes of high calcium in adults, covering about 80% of cases.
And other causes usually have low PTH.
Generally, yes. The body tries to compensate. The main exceptions are long-term lithium use and familial hypercalcemia, FHH.
FHH. That sounds similar but different.
It is. FHH is a rare genetic disorder affecting the kidney's calcium sensor. Result is lifelong, usually asymptomatic hypercalcemia with normal or mildly high PTH. Crucially, FHH patients don't get the bone disease or kidney stones of HPT. And since it usually shows up before age 30, it's rarely a new diagnosis in older adults. No treatment needed, a key differentiator.
So what's actually going wrong inside the glands in primary HPT?
Essentially, the normal calcium feedback loop breaks down. The glands stop listening. 1 or more glands enlarge and secrete PTH inappropriately. The resulting high calcium comes from PTH hitting the bone, kidneys, and indirectly the gut. Normally, high calcium inhibits PTH, but in an adenoma, the cells are less sensitive to calcium's braking effect. They need a higher calcium level to even start slowing down.
They have a higher set point.
Right. In hyperplasia, though, you just have more cells overall producing excess PTH, but they do maintain normal sensitivity. Subtle difference, same result. Primary HPT and hypercalcemia.
And the causes are usually adenoma, hyperplasia, or rarely cancer.
Correct. Single adenoma is most common, 85–90%. Multi-gland disease, double adenoma, or 4-gland hyperplasia in 10–15%, and cancer in less than 1%.
What might trigger this? Are there known risk factors? Some seem surprising.
There are. One clear factor is ionizing radiation exposure to the neck, from external beam radiation, nuclear accidents, even radioactive iodine for thyroid issues.
But with a long delay.
Yes, a significant latency period, typically 25 to 40 years. Another known cause is chronic lithium therapy. Up to 15% of patients on it for over a decade develop HPT. Lithium messes with the calcium sensitivity and set point. It's also linked more often to hyperplasia.
Okay, and what about thiazide diuretics? They come up often.
Right, they don't cause HPT, but they can unmask it. They reduce calcium excretion by the kidney, raising blood calcium. If someone has underlying HPT, thiazides can push their calcium into the high range.
So they reveal it, like pulling back a curtain.
Exactly. Take them off the thiazide, they stay hypercalcemic if they have true HPT.
And most HPT is sporadic, but there's a familial component too.
Yes, about 3–5% of cases are familial. Part of syndromes like multiple endocrine neoplasia MNN1 or 2A, H-Pecty jaw tumor syndrome, or familial isolated HPT. These often present younger, with a family history.
Okay, beyond just high calcium, what does HPT actually do to the body? It seems systemic.
It absolutely is. While maybe 80% are diagnosed incidentally now, many still have diverse symptoms from calcium's effects everywhere. A recent large study found 35% had objective end organ effects at diagnosis, like osteoporosis or kidney stones, and 62% developed them within 5 years.
That's a high percentage. What are the main effects?
Let's break them down. Renal. Kidney stones are common, up to 20% symptomatic, 10% recurrent, even silent stones. Also nephrocalcinosis, frequent urination, thirst, reduced kidney function.
Okay.
Skeletal. Bone loss is key, especially cortical bone like the radius. But newer scans show trabecular bone is hit too, increasing vertebral fractures. Untreated HPT leads to significant bone density decline, bone pain, fragility fractures, and rarely now that dramatic osteitis, fibrosis, cystic.
Like the salt and pepper skull.
Exactly, though less common now with earlier diagnosis. Neuromuscular neuropsychiatric, often reported fatigue, weakness, depression, anxiety, memory loss, poor concentration. Importantly, studies show these can improve significantly after surgery.
That's huge for quality of life.
It is gastrointestinal. Reflux, constipation, abdominal pain, or vomit. Nausea, vomiting, pancreatitis are rare, usually with severe hypercalcemia. Cardiovascular. Can worsen hypertension, cause valve disease, calcifications, premature atherosclerosis, arrhythmias. The impact is widespread.
So how does a doctor officially diagnose primary HPT? It seems like a careful process.
It is. Key lab tests are serum total calcium, intact PTH, creatinine, and 25-hydroxyvitamin D, phosphorus, alkaline phosphatase, and a 24-hour urine collection for calcium and creatinine are also valuable.
And the classic definition.
Hypercalcemia with an elevated or inappropriately normal intact PTH. Remember, PTH over 25 pgml with high calcium strongly suggests primary HPT. Always ask about biotin supplements, stop them weeks before pesting, they interfere. Repeat calcium to confirm it's persistent. And correct calcium for albumin levels.
Right, for the true active calcium level.
Exactly. Check vitamin D deficiency can worsen HPT. Check kidney function to rule out CKD. The 24-hour urine calcium is critical. High levels over 400 milligrams mean higher stone risk and indicate surgery. Low levels, under 100 milligram, point towards FHH.
Though you mentioned the CCCR ratio for differentiating is maybe less useful now.
Yes, recent large studies question its routine use, as many surgically proven HPT patients had low ratios without having FHH. Clinical practice evolves.
And HPT doesn't always present classically, right?
Yeah.
There are atypical forms.
Correct. That adds complexity. Normocalcemic primary HPT is one. Here, PTH is high, but serum calcium, total and ionized, is normal with no other cause for high PTH. Usually found when investigating kidney stones or osteoporosis, it's increasingly recognized. Maybe 16% progress to hypercalcemic HPT. Ionized calcium should be checked.
But why is PTH high if calcium is normal?
That's the puzzle. It suggests subtle disruptions in the feedback loop. The body's working harder, maybe the set point is slightly off. Management is similar due to similar complications.
Okay, and the other variant?
Normohormonal primary HPT. This is hypercalcemia, but the PTH is normal, yet inappropriately, so it should be suppressed by the high calcium. It's uncommon. Diagnosis is challenging, often one of exclusion. Repeated tests, positive localization scans can help guide towards surgery. Despite atypical labs, symptoms and cure rates are similar to typical HPT. Recognizing these requires real expertise.
So the full diagnostic workup isn't just blood tests. Imaging. Kinetics.
Absolutely. All primary HPT patients need a DXA scan for bone density. Remember, distal radius is most affected. Renal and spine imaging should be considered due to fracture and silent stone risk, and genetic counseling testing for those under 40 with multi-gland disease or a suggestive family history. It's a comprehensive picture.
Which brings us to management. Surgery seems key.
Parathyroidectomy is the only curative treatment, so all patients should be offered surgery as the definitive option. The established indications are clear. For symptomatic patients, kidney stones, impaired renal function, high urine calcium, bone issues like osteoporosis, fractures, or neurocognitive symptoms.
And for asymptomatic patients.
Surgery is also indicated if they're under 50, have calcium more than 1 milli-GDL above normal, or can't do long-term surveillance.
Why under 50 specifically?
It's about cumulative risk over a longer lifetime. Younger patients declining surgery are more likely to develop complications later. Plus, surgery is more cost-effective than lifelong monitoring and often improves quality of life even in asymptomatic cases.
Okay, if surgery is recommended, the next step is finding the gland. Let's talk localization imaging.
Crucial point. Imaging is not for diagnosis. It's for patients already diagnosed with HP2 to help plan surgery, especially finding ectopic glands.
And negative scans don't rule out surgery.
Correct. Cure rates are still excellent even with non-localizing scans, though the surgery might need to be more extensive, like a bilateral exploration. Imaging is also less accurate for multi-gland disease.
What are the main tools?
Ultrasound and sesame scintigraphy are the workhorses, often used together. Ultrasound is often first. Available, cheap, non-invasive. Abnormal glands look like round hypoechoic masses. Accuracy depends on skill, sensitivity around 76%, but only 35% for multi-gland disease. Can't see into the chest.
Right.
Sesame scintigraphy uses a radio tracer. Hyperactive glands grab it. Combining with SPECT gives 3D info, better localization, especially for ectopic mediastinal glands. Sensitivity is about 79% for adenomas, 44% for multi-gland. Limitations, radiation, less sensitive for small glands.
Okay, US and sesame often combined. What else?
4DCT is newer. It looks at contrast enhancement and washout patterns. Sensitivity is high, 81, 89%, even 55% for multi-gland. Great for small adenomas and reops, but more radiation and contrast. MRI is usually second or third line. Lower sensitivity, but great anatomy, no radiation. Useful in tough reop cases.
Right.
And PCT with new tracers like 18F fluorocholine looks very promising. Higher sensitivity than sesame in early studies, even for small glands. Still under investigation, though.
So multiple tools, chosen based on the situation.
Exactly. The goal is usually concordant findings if possible.
Now, for the surgery itself, what are the approaches?
The definitive treatment is removing all hyperfunctioning glands. This is done via either a focused parathyroidectomy or a bilateral neck exploration. A focused or minimally invasive parathyroidectomy, MIP, is usually outpatient, small incision, targeting the gland localized preoperatively. A bilateral neck exploration is more extensive, visualizing all 4 glands, then removing the abnormal one.
And the game changer during surgery is that real-time feedback.
Intraoperative PTH, IOPTH monitoring, yes. It tells the surgeon when to stop, confirming no hyperfunctioning tissue is left behind. It boosts cure rates for MIP significantly, up to 97–99%.
How does it work? Blood draws during the operation.
Exactly. Samples before incision, before excision, then 5 and 10 minutes after removal. PTH drops fast due to its short half-life. The Miami criteria look for a 50% drop at 10 minutes from baseline. Dual criteria also require the final PTH to be normal. Both yield excellent cure rates. If PTH doesn't drop, you might wait longer or explore further.
MIP has advantages then. Smaller incision, faster recovery.
Yes, and lower rates of transient hypocalcemia. Bilateral exploration is needed if focused fails, if hyperplasia is known or suspected, in familial HPT, or with unclear imaging.
And during bilateral, you look for all 4.
Yes, and compare them. You also have to be ready for ectopic glands, remember the thymus for inferior, tracheoesophageal groove for superior. If all 4 glands look abnormal, you do a subtotal parathyroidectomy and remove 3 and most of the 4th, leaving a small, viable remnant marked with a clip.
Okay.
A transcervical thymectomy is often done too, since that's the top spot for extra glands. IOPTH can still be useful in bilateral cases.
How do surgeons confirm it's actually parathyroid tissue they removed?
Usually visually, but if uncertain, frozen section analysis or even aspirating the tissue and measuring PTH in the sample can confirm it, though often unnecessary if IOPTH confirms cure. Other adjuncts, like near-infrared autofluorescence, can help visualize glands. Nerve monitoring is common, especially in reops. Meticulous dissection prevents spilling cells, parathyromatosis, or damaging blood supply to normal glands.
And if a normal gland is devascularized?
It should be autotransplanted, moved to a muscle like the sternocleidomastoid or forearm, and marked.
And some newer approaches avoid neck scars entirely.
Yes, endoscopic or robotic routes through the armpit or mouth. Offered at specialized centers. More complex, longer procedures currently.
What about after surgery, recovery and potential issues?
Post-op care is crucial. Observe for neck hematoma, rare but serious, and hypocalcemia symptoms. Discharge is often same day or overnight. Hypocalcemia is uncommon after single adenoma removal, more likely after subtotal. Symptoms are numbness, tingling, cramps. Treated with calcium and vitamin D. Patients are educated beforehand. Cure is confirmed by normal calcium levels at 6 months post-op.
Okay, but what if someone isn't a candidate for surgery or isn't ready? What are the medical options? Recognizing they don't cure it.
Right, the goal is control, not cure. Patients need ongoing monitoring. Annual calcium, creatinine, GFR. bone density every 1-2 years. If things worsen, significantly higher calcium, lower GFR, osteoporosis, stones, fractures, then surgery should be reconsidered.
And the medical treatments themselves.
Hydration is key. Cinecalcet is important in the calcimetic. It sensitizes the KSR, lowering PTH. Approved for severe HPT in non-surgical candidates and parathyroid cancer. It lowers calcium in PTH, but importantly, doesn't stop bone loss. Bisphosphonates improve bone mass in those with osteoporosis, but don't affect calcium or PTH. Combination therapy, cinecalcet plus bisphosphonate, can be considered. Thiazides can lower urine calcium to reduce stone risk.
But ultimately, surgery is superior.
Yes, for primary HPT, surgery is more effective for treating and preventing complications and more cost-effective long-term. It remains the definitive treatment.
And the outcomes after successful surgery are generally very good.
Excellent. Cure rates by experienced surgeons are 95–99% for sporadic primary HPT. Complications like permanent hypoparathyroidism or nerve injury are rare. Bone health improves significantly with increased bone mass and reduced fracture rates long-term. Renal health benefits, too, with fewer stones and stabilized kidney function, and neurocognitive symptoms often improve, enhancing quality of life.
Great. Now let's briefly touch on the other forms, secondary and tertiary HPT. These aren't primary gland problems, right?
Correct. Secondary HPT is initially a physiologic response to low calcium. The glands ramp up PTH trying to fix it, but the underlying problem persists. PTH is high, calcium is low or normal.
Common causes.
Most common are chronic kidney disease, CKD, severe vitamin D deficiency, and calcium malabsorption. Vitamin D deficiency and hypocalcemia must be treated. In CKD, it's complex. Kidneys can't excrete phosphate well, so phosphate rises, binding calcium and lowering free calcium. They also can't activate vitamin D effectively, reducing gut calcium absorption.
So chronic low calcium and high phosphate drive the parathyroids.
Yes, leading to PTH hypersecretion and gland hyperplasia. It's a multi-system issue. Most CKD patients develop secondary HPT, usually managed medically. Phosphate control, calcium calcitriol supplements, sometimes cinecalcet.
When is surgery needed for secondary HPT?
For medically refractory or complicated cases, about 1–2% per year. Indications include very high PTH, sustained hypercalcemia, despite secondary HPT usually starting with low calcium, severe bone disease, or calciphylaxis. Surgery involves subtotal or total parathyroidectomy with autotransplantation plus thymectomy. Kidney transplant is the ultimate fix for the underlying metabolic issues.
And tertiary HPT, that's related but different.
Yes. Tertiary HPT is when the glands become autonomous after prolonged secondary HPT, usually in CKD patients, especially after a kidney transplant. PTH stays high, but now calcium becomes high too.
The glands just keep overproducing, even after the trigger is gone.
Essentially, yes. It often involves nodular hyperplasia. This persistent HPT post-transplant increases risks of bone loss and graft failure. Treatment is cinecalcet or parathyroidectomy. Surgery is superior for normalizing labs and improving graft survival, but still underutilized. Indications include persistent high calcium, bone loss, symptomatic disease. Pre-transplant surgery can be beneficial.
And post-op management is tricky here too.
Very. Profound hypocalcemia is common due to hungry bone syndrome, bones rapidly sucking up calcium. Requires inpatient monitoring, ivoryl calcium, calcitriol. Preoperative calcitriol loading can shorten hospital stays.
Okay, let's briefly cover two critical life-threatening complications, calciphylaxis and hypercalcaemic crisis.
Right. Calciphylaxis or calcific uremic arteriolopathy is devastating. Painful skin lesions progress to necrosis due to microvascular calcification and clotting.
Primarily in kidney patients.
Mostly ESRD patients with secondary HPT, but can occur elsewhere. Mortality is tragically high, 50–80%. Pathogenesis involves high phosphate, high PTH, maybe warfarin use. Diagnosis combines clinical picture and skin biopsy. The HPT link isn't perfectly clear, but parathyroidectomy may benefit some with high PTH. Treatment is multifaceted. Total parathyroidectomy is often preferred surgically due to the severity, though its impact on survival is still debated.
And hypercalcaemic crisis, an endocrine emergency.
It is. Rare, life-threatening, usually severe HPT or malignancy, defined often as calcium O14 mg/dL with organ dysfunction. Acute onset, often with dehydration trigger.
Severe symptoms across system.
Yes. GI, nausea, pancreatitis, renal, AKI, stones, cardiac arrhythmias, heart blocks, CNS, lethargy, coma. Patients often have palpable neck masses, very high PTH and calcium.
Management is urgent.
Absolutely. Goal is rapid calcium reduction before surgery. aggressive FeV fluids, furosemide after rehydration. Bisphosphonates, like zoledronic acid, are first line to inhibit bone breakdown. Calcitonin is a temporary bridge. Refractory cases might need dialysis or denosumab calcit. Once stable, localize the gland, often large, ectopic, maybe cancer in 5%, and perform parathyroidectomy expeditiously. Post-op bone hunger can cause severe hypocalcemia needing careful management.
Finally, the rare but serious entity, parathyroid cancer.
Extremely rare, less than 1% of primary HPT. Affects men and women equally, unlike benign HPT. Often sporadic, but linked to HPT-JT, and familial isolated HPT, often involving CDC73 or GCM2 mutation.
And usually functional, producing PTH.
Almost always. Patients present with severe HPT, often very high calcium, 43-10x normal, often palpable neck mass, maybe hoarseness, more likely to have concomitant bone and kidney disease than benign HPT patients.
Diagnosis is tricky, not just histology.
Correct. Definitive diagnosis is based on invasion of adjacent tissues or metastasis, usually found during surgery. Microscopic features can overlap with benign adenomas. Intraoperatively, cancer looks different. Large, 3 centimeters, firm, grayish-white, stuck to surrounding tissues like the thyroid or muscles. Benign adenomas are soft and easily dissected.
Treatment is aggressive surgery, then?
Yes. In block resection, removing the tumor and anything it's invaded, sometimes including the nerve. Meticulous technique to avoid spilling tumor cells. Lymph node dissection only if nodes are clearly involved.
Prognosis is difficult.
Recurrence is high, 40–70%, usually within 2 to 5 years. Locoregional or distant, lung bone. Resection of recurrence helps control hypercalcemia. Radiation and chemo are generally ineffective. Median survival is around 75 months overall. Survival rates drop significantly with metastases. Patients die from metastatic disease or intractable hypercalcemia, managed medically with bisphosphonates or cinacalcit.
Shifting now to when HPT runs in the family of the familial forms.
Right, 3 to 5% of primary HPT is familial. Syndromic forms are MN1, MN2A, MNN4, HPT-JT. Non-syndromic is familial isolated HPT. Family history is key for screening. Genetic counseling testing is recommended for young patients, 40, with multi-gland disease, or those with suggestive family history or features. Knowing it's familial often guides towards more extensive initial surgery.
Can we quickly outline the main syndromes?
Sure. MN1 is most common familial HPT, MNN1 gene mutation. HPT affects nearly all by age 50, usually multi-gland disease, associated with pituitary pancreatic tumors. Surgery is subtotal parathyroidectomy plus thymectomy. MNN4 is similar, different gene. MNN2A involves RET mutation. HPT less common, 15 to 35%, often single adenoma or hyperplasia, associated with medullary thyroid cancer and pheochromocytoma. Crucially, pheochromocytoma must be ruled out or treated before parathyroid surgery to avoid crisis. Surgical approach varies, often just removing enlarged glands.
Okay, pheo first. Critical point.
Absolutely critical. HPT-JT involves CDC73 mutation. HPT plus jaw tumors, renal uterine issues, high risk, 15 to 20% of parathyroid cancer. HPT is often single gland, so focused surgery possible if benign, en bloc if cancer. CDC73 testing recommended for all parathyroid cancer patients. Familial isolated HPT is HPT history without other syndromes. Multiple genes involved, MN1, CDC73, GCM2. High rate of multi-gland disease often warrants bilateral exploration, though extent is debated.
And long-term outcomes differ for familial HPT.
Yes, significantly higher recurrence rates, 17–46% in MNN1, lower but still elevated in others, compared to sporadic HPT. Cure rates are lower overall. Lifelong follow-up is essential for all familial HPT patients.
Finally, let's tackle the challenge of reoperative surgery for persistent or recurrent HPT.
This is tough. Operative failure happens in 1 to 5% of sporadic cases, higher in familial or renal HPT. Persistent HPT means calcium never normalized post-op. Recurrent HPT means it returned after 6+ months of normal calcium.
Reoperation is harder.
Much harder. Scarring, distorted anatomy, higher risk of complications like hypoparathyroidism and nerve injury. Success hinges on meticulous preparation. Confirm the diagnosis again. Get detailed history. Review all prior operative pathology reports, previous imaging. Understand what was done, what glands remain.
Localization is even more critical here.
Paramount. Need at least 1 positive study, ideally 2 concordant. 4D CT often performs better than sestamibi in reop setting. MRI, PT-CT might be needed. Selective venous sampling is a last resort if non-invasive fails. If localization fails, usually recommend non-operative management.
And the surgery itself. Any special considerations?
Usually a focused exploration based on localization to minimize dissection in the scarred field. IOPTH and nerve monitoring are very helpful adjuncts. Cryopreservation is an option at some centers, freezing some removed tissue as an insurance policy. If permanent hypoparathyroidism occurs later, the tissue can be thawed and autotransplanted. Used rarely, but a safeguard in high-risk cases like reoperations or total parathyroidectomy.
Wow, what an incredible deep dive into the parathyroid glands. From their late discovery in a rhino all the way to cutting-edge genetics and really complex surgical approaches. It's clear these tiny glands pack a huge punch. We've covered their history, their intricate physiology, the nuances of primary, secondary, tertiary HPT, critical complications like calciphylaxis and cancer, right down to the challenges of reoperation. Well, it's a whole world.
It truly is. And understanding these nuances, elevates your comprehension beyond just the basics. This deep dive should give you, the listener, a new appreciation for this intricate dance of hormones and minerals. It really raises an important question for you to think about. Given this incredible journey of discovery and the ongoing complexities we still face in diagnosis and treatment, what future breakthroughs do you envision? What might further refine our mastery of these tiny yet mighty regulators? Could we even see non-surgical cures for more types of HPT down the road?
That's a fantastic thought to leave you with. Until next time, keep digging, keep learning, and stay well informed.